Sarcopenia versus MELD and MELD sodium predicting waitlist mortality in cirrhotics. Basically, the waitlist mortality term used predominantly in the donor liver transplant setting, and it means that the patient died while awaiting the transplant after listing, or patient become too sick for the transplant and it has been removed from the transplant list. So whatever the scoring system we use for the allocation, that depends on the three ethical principles, that's equity, benefit and utility. Equity means organ access, the access to the organs to the all patients irrespective of the disease etiology or severity of the disease. Benefit that as compared, they gets most benefited as compared to the other treatment modalities, and utility, that is the gain in the survival, that is post-transplant. There are a lot of controversy regarding this objectivity. So whatever the allocation policies are there, we have to recalibrate that policy based on this equity, benefit and utility, depending upon change in the profile of the patients and the target population. And that has happened in the literature. If you see from the origin of the Mayo TIPS model scores to MELD score, which was published by Dr. Kamath et al. In Hepatology 2001. Basically, it was devised originally for the elective TIPS patients undergoing TIPS for varicose bleed and the refractory ascites. Subsequently, it was shown that it correlates well with short-term mortality, that is 90-day mortality on the wait list. And the MELD system was used by the US liver allocation in the 2002. After that, almost 1/3 of the patients on the waiting list were dying. So there were some other factors which caused this early mortality in these patients. So people start searching other factors, and most important factor is the sodium, which was initially proposed by Roof et al. In AJT 2004, and that showed that based on that the MELD sodium score was proposed. And subsequently publication, the landmark publication by Kim published in NEJM et al. After that, the MELD score was used in US allocation system. And subsequently, based on equity, utility and benefit, there was policies also came, that is share 35, initially it was share 15 policy, that is the allocating the organ either regionally or nationally, initially before giving to them local patients with less than MELD 15. Because initial that report by the Marin et al. Showed there was a limited post liver transplant survival, that is 1 year survival was limited benefit in these patients. Subsequently, it was found to be the policies were changed. It came to the share 35 policy, and recently the share 21 policy has been proposed, that is allocating liver regionally and nationally to the MELDs more than 21. After the subsequent MELD derivations has been come, that is delta MELD, meso index, I MELD, especially used in excluding the INR, and lots of other things are there. I will not go in the details. Important is the MELD sarcopenia will come later on. And some recent developments are there, especially MELD, that is GREL sodium, that is based on GFR in the cirrhotic patients, and MELD3. It uses, apart from bilirubin, INR, and it uses especially the sex of the patient and the albumin of the patients. So it gets benefit to the female recipients which are awaiting on the transplant list. First, affecting the MELD sodium and sarcopenia, affecting the weight loss mortality, you have to see other factors apart from the severity of the liver disease, which can affect the liver wait list mortality. That is sex of the patient, especially the female patients. We can get a size mismatch, underestimation of the renal function, especially females, and the sarcopenic patients. There will also subjective variables, especially females. The perception of the frailty, we perceive frail more in the females. The racial differences based on the CLD etiology and the vulnerable communities, that is the minority community, especially in US has found the Hispanics and Black African American. And there are implied bias from the providers, that is health treatment givers, and the structural racism. Also, there are geographic factors, the distance between the transplant center and where the patient is staying, and which can lead to, depends on the cold ischemia time, also, and access to the hospital. Among the severity of the liver disease, we have lots of objective parameters, the bilirubin, INR, creat, sodium, albumin, sarcopenia, but there are lots of limitations or caveats in this parameter, especially bilirubin, which can be affected by transfusion, hemolysis. Especially the cholestatic patient, they can get an upper hand. INR up to 40% interlaboratory variations. The creat also gets affected by the muscle mass. Also the sodium level, which can be affected by the hydration status, free water intake, and correction treatment. And there are the subjective parameters which can have important impact on the waitlist mortality, that is ascites and hepatic encephalopathy. And most important, other important factor is the socio-economic factors, that is education, language, the caregiver, the housing, the disorganized social environment, and the type of the health insurance and the availability of the health insurance for the transplant. Now we see what is the current profile of the patients on the wait list. If you compare in 2009 to 2019, the age of the patient is increasing, especially the patients are becoming more older. Almost is 13.5% in 2009, and now in 2019, it is almost approximately 30%. So age of the patient is increasing over the years. If you see the etiology of the patients in the waitlisted patients, the etiology, the non-viral etiology has coming down because of the landmark, the eradication by the antivirals in hepatitis C. Nowadays the NFLD and the alcohol-related liver disease are increasing. Also the SCC on the background of the NFLD are also increasing. Also the change of the profile of the patients on the wait list, the MELD score is also increasing. If you see the MELD score more than 30 in 2019, almost 30% of the patients are on more than MELD 30 as compared to the 15% patients in 2009. And all that has caused the decrease in the predictive power of the MELD score over the years, especially if you assess as a binary model, which is assessing the 90-day predictive mortality without taking contribution from the follow-up time. The concordance index had decreased from 0.8 to almost 0.6. So recently there was a recent validation study published more than 700 patients in the TIPS cohort, and it was recalibrated in the non-TIPS cohort. It was published in Hepatology 2021, and it has proven globally that the predictive power of the MELD score has fallen down. The C-statistic is 0.6, that is poor concordance between the observed versus predicted mortality, especially due to change in the etiology, and it was found in the NFLD patients, that is non-viral etiology. So important is determining the low MELD patients, because almost today also more than 50% of the patients on the wait list, they have MELD score less than 20. So apart from MELD, there are some other factors which causes the early mortality in this group of patients, and most important about the sodium as already discussed. If you categorize this patient with mild, moderate, and severe hyponatremia, especially the patients with sodium level below 135, we see significant survival difference between this group of patients. And this was a landmark publication by the Kim in NEJM 2008. And in the sodium level falls from the 140 to 125, we see significant impact on the wait list, death of the recipients who are waiting on the transplant list. And this MELD sodium has significant contribution up to the MELD 38, and especially in the low MELD patients and with the severe hyponatremia, they get additional 13 points the increase in the mortality risk. So after use of MELD sodium allocation policy in US, there was significant marked decrease in the transplant, that is the waiting list mortality, which are reduced by 34% and increasing the transplant probability by 20%, even after matching all the factors like ascites, region, dialysis, age, and other also factors like MELD and propensity score matching was performed. So apart from these factors, sodium and ascites, we have to important to consider the stage of the cirrhosis. That we know the natural history that they are coming the compensated phase and the decompensated phase. That is stage 1, they have no varices or no ascites. Stage 2, they develop varices. Stage 3, they develop bleed. Stage 4, they develop ascites, and stage 5, the ascites with second episode of decompensation, that is bleed. And the stage of as the stage of the disease increases, the risk of the mortality also increases. And in the stage 5, that is when they develop the second episode of decompensation, almost 50% will die on the wait list. So next important factor is the impact of the ascites, that is refractory ascites or moderate ascites. You stratify this patient according to MELD, that is low MELD and the high MELD. The impact of the ascites is significantly seen in especially the low MELD patients, and they have poor survival on the wait list. Also, it is very important to mention that the impact of the moderate ascites is seen irrespective of the sodium level. Even in patients with normal sodium level, you can see significant mortality on the wait list. Next important factor is the hypoalbuminemia, which importantly predicts the late weightless mortality. If you see the UNOS data, the 64% of the patients waited more than 1 year, 66% of the patients were on less than, had MELD less than 20, and the 65% of the deaths occur after 90 days, and the 40% of the deaths occur after 1 year. And these patients, we categorize these patients according to MELD and the serum albumin. The patients with high MELD with hypoalbuminemia, almost 80% will die within 3 months. And the impact of the hypoalbuminemia seen especially in low MELD patients with severe hypoalbuminemia, they have significant lower survival on the wait list. Next important factor is hepatic encephalopathy, which is not caused by the MELD. If you see the severity of the hepatic encephalopathy as increases, the survival on the wait list also decreases. If patients with OHT, that is grade 3-4 history of the grade 3-4 HE, the 90 days the wait list mortality almost increases to 25% as compared to the 4% in the no HE. That is, patients with OHT HE, almost there is a 5-fold increase in the wait list mortality. And what is the cause of mortality in this patient? If we see, the majority will die because of the liver-related complications, and among the died, almost 50% will die because of infection, next followed by multi-system organ failure, next will be bleed following the varicose bleed, other is the liver-related malignancy, that is SCC. And if you compare the mortality causes between the low MELD and high MELD, they are similar, there is no difference. If you see the number of episodes of complication and the MELD score correlation, there is no correlation between the MELD score and the number of episodes of complications. Even this complications like SBP, hydrothorax, AKI, bleed, they can happen in the low MELD patient. And each additional episode of complication, it increases the waitlist mortality almost 5-fold. And if you see the risk factors for the waitlist mortality, this is a paper published in AGD 2017, and they analyzed the risk factors. The most highest the weightage was to the severe hypoalbuminemia. That was the hazard ratio of almost the 5-fold increase in the mortality, followed by hepatorenal syndrome, hepatic hydrothorax, ascites, and malnutrition. They also compared the factors between the wait-listed patients and non-wait-listed patients. The factors were the similar, but the malnutrition has found to be significant impact on the wait-listed patients with hazard ratio of 8.6. Now comes to the ACLF, because the ACLF is a completely different ballgame, and this is a group of, it's basically a multi-organ syndrome with acute hepatic decompensation followed by ascites, jaundice, and increased 28-day mortality. In this, the mortality is driven by especially the extrahepatic organ dysfunction, and if we compare between the expected and predicted mortality, which stratified by the MELD score, even the ACLF grade 3 patients, that is with organ failure more than 3, they die even on the lower MELD patients, and that is not caused by the MELD score. And this was, see the cutoffs of the median MELD score at the transplant. If you take a share 35, only 9% of the patient will reach that cutoff to have a transplant, and even see other centers, only 17 to 35% of the patients will reach the medial sodium cutoff for the transplant, and other patients will not have access to the liver transplant. Even after, if you compare between the pre-share 35 and post-share 35 era, and there was after share 35 policy, there was significant decrease in the 90-day waitlist mortality and increased probability of the transplant in ACLF patient. But if you do subgroup analysis with patient with 4 to 6 organ failures, there was no significant difference in the waitlist mortality, and these patients get less prioritization in the MELD score setting. Now come to the, this was a publication published in Gastroenterology 2019. If you see the orange bars, especially the ACLF patient with a low MELD score, they have a higher mortality than the high MELD score patient with no ACLF. Even the ACLF, they across the high MELD score, they have higher mortality across the all MELD score. So the MELD doesn't predict the mortality in the ACLF group of patients. So to have assess the impact of the extrahepatic organ failures, the people started looking at these factors, and the lots of score has come. That is Cliff ACLF score, and recently the upper cell group has published the R score, and it was found to be superior to MELD in predicting mortality. Recently the North American group has also come across their own score based on the organ failure. They take more than 2 organ failures, and they found to be slightly more better than R score, but the p-value was not statistically significant. Next is there are lots of indication for standard exception point MELD across the different countries where the risk of mortality is not well assessed by the MELD score. The important is the SCC, because SCC patients, they are well preserved, and the low MELD patients, and they are not properly assessed by the MELD. So they will get less advantage in the sickest first policy. So there the exception points has been allocated, but because of the exception points, the SCC patients will get more access to the transplant. So recently the US has changed their policy of cap and delay policy, that is you wait for 6 months without giving exception point to assess the biology of the tumor, and after the 6 months they demand within the Milans you give the MELD exception point equivalent to the what is the median regional transplant minus 3 points. There are no extra exception points, and the MELD has been capped at 34. Now come to the sarcopenia. Sarcopenia, basically it was loss of muscle mass, and if you take a recent European working group, they take into both to define the sarcopenia. It is not just the muscle mass and the quality. The quality is assessed by either liver attenuation, or I already told that it is seen on the histopathology, myosteatosis. We have to take into account the muscle strength and the muscle performance, which the muscle strength is assessed by the hand grip, and the muscle performance is assessed by the gait speed. So you have to take all these 3 factors into account while assessing the sarcopenia. Before I will go to the assessing the impact of the sarcopenia, the waitlist mortality, you should know all these things. There are the sex differences, especially in the male patient, they have a higher muscle mass, and as the stage of the liver disease severity increases, it correlates with the sarcopenia. Also, the sarcopenia also increases in the male, but not in females. Next, the impact of the etiology of the liver disease. Because if even in our setup we see lots of patients with alcoholic cirrhosis and the NAFLD, and these patients, as compared to the NAFLD, the alcoholics, they have lower muscle mass at the presentation, and they lose muscle rapidly over the days. So why this is important? Because the patients with lower muscle mass at presentation, rapid muscle mass, and the higher MELD at the presentation, they have a higher risk of waitlist mortality. Theory was proposed because the alcoholic, why they lose muscle, because the increase hypersensitivity of the muscle to the hyperammonemia, leading to the muscle loss. Next, there is no correlation between the MELD score and the sarcopenia. Also, there is a poor correlation between the albumin and the sarcopenia, and there is a poor correlation between the sodium and the sarcopenia. Next important thing, the sarcopenia, these patients are prone for the ACLF, especially these prone. Why? Because when the sarcopenia triggers the ACLF, the mortality is defined by the number of extrahepatic organ failures, not the triggering event, that is the sarcopenia. So this is our paper, which is published in Journal of Clinical and Experimental Hepatology. If you see, this is 115 patients which underwent LDLT. If you see carefully the data, the sarcopenia patients, they have increased risk of ACLF, that is refractory ascites, and the increased risk of complication, that is infection, hepatic encephalopathy, and renal dysfunction. And most of these our patients, the MELD score, they have the high MELD score as compared to the literature. The median MELD is being 24. Whatever the papers in the sarcopenia, whatever I come across, they have low MELD, which is assessing the median MELD from 16 to 18. If you see impact of the sarcopenia on the waitlist mortality, obviously the sarcopenic patients have poor survival on the wait list, and you stratify these patients into low MELD versus high MELD. The effect is more seen in the low MELD patients, that is, they have poor survival in low MELD with sarcopenia. The next dangerous combination is refractory ascites. We see lots of patients, even alternate patient we are seeing in the OPD with refractory ascites with history of multiple LVPs with combination of the sarcopenia. The waitlist mortality increases almost 5-fold, and we have to look carefully and monitor these patients, because if we detect this patient early, we can intervene at the correct time. This was a meta-analysis published in American Journal of Transplantation, taking consideration into impact of sarcopenia on the waitlist mortality. And there were 4 studies, and they have concluded that the sarcopenia increased the waitlist mortality almost 2-fold. So subsequently, the model was proposed based on the muscle mass, that is MELD sarcopenia, and next is a MELD sarcopenia encephalopathy score. And both these cutoffs take the L3 skeletal muscle index, which is assessed on the CT. But disadvantage of the CT is the radiation exposure, cost, access, and reproducibility. If we compare with the MELD score, they have better concordance index for the 3-month waitlist mortality as compared to the MELD, and especially in the low MELD patients also they have better concordance. So it is not the muscle mass. Now the concept has gone further. We take into consideration the muscle function also into while assessing the sarcopenia. We take MELD hand grip strength, 6-minute walk test, and recently the liver frailty index, because there is a conceptual similarity between the frailty and the sarcopenia, though sarcopenia is a part of frailty. And the liver frailty is assessed by the grip strength, time chair stands, and the balance testing. And both of these models show better predictability in 3-month waitlist mortality as compared to the MELD CT or the MELD sodium. The advantage of these models are that they are objective. You can do bedside and the reproducibility, so that we can categorize this patient into mild, moderate, and severe sarcopenia. And patients with mild and moderate sarcopenia, we can intervene by the lots of intervention therapies with exercise, diet, as Sir has told, there is branch and amino acids, and the hormonal treatment. But what is the challenges in clinical application of the sarcopenia is the standardizing muscularity assessment. Whatever the cutoffs they have taken from the cancer patients. Recently, Dr. Jaya Benjamin has published that assess the cutoff levels in the alcoholic cirrhotics, and also the Carey et al. Has published the newer cutoffs for the cirrhotics. So there is no standardization. And the cutoff value is measured for the sarcopenia by the cross-sectional imaging. There is no comparison between, because few studies assess taking a horse muscle thickness, or few taken as a muscle area at the L3 level. Next is the muscle function, is already told. And next is sex-specific sarcopenic differences, that is male versus female. And the most important is the referral practice of the patients and the regional specific patterns of the pre-transplant selection of these patients and the median MELD at the transplant. For example, if you take our center, we do median MELD almost is a 24. If you take other centers, they do, even in Delhi, they do transplanted lower MELD. And if you are transplanting them then lower MELD, the impact of the sarcopenia on the waitlist mortality will not be assessed properly. So from this, what I understood after working 5 years in the transplant unit, if we consider the patient with low MELD patients, the underlying hyperdynamic circulation with portal hypertension, if you take a HVPG, if the HVPG is not responding to the medical treatment and these patients are found to increase prone for the sepsis and multiple liver-related complications, they have altered neurohormonal changes. If you take a hyperdynamic physiology, they have altered cardiovascular, that is hyperdynamic circulation, with increased ejection fraction, diastolic dysfunction, and chamber dilatation. But we don't know whether these cardiophysiological changes precede the decompensation, and this area to be looked up. Next is the HVPG. Also, there is a lots of work, but the HVPG usually because of the invasive nature, there's a reproducibility issue. But now lots of research is going on the splenic elastography, which correlates well with the HVPG. So these patients over the time develop variceal bleed, refractic ascites, and hepatic encephalopathy, and they are prone for the infections and the hyponatremia and renal dysfunctions. So once the hyponatremia and renal dysfunction develop, the MELD increases. Also, the low MELD patient over the time they have a risk of developing SCC, that is 10% per year. And next component is the component of the malnutrition, sarcopenia, and frailty. So basically, when the sarcopenia develops, the progression of the CLD worsens, and they become too sick for the LT, and they go to the mortality. If we intervene at the correct time, we can save lots of these patients by timely transplantation. So I will come to my conclusion. The sarcopenia have high waitlist mortality in the cirrhotics. And the limitations of the MELD, they cannot assess the nutritional and functional status of the cirrhotic patients. The MELD sarcopenia, though it was not completely validated prospectively, it has shown improved prediction of the mortality in the cirrhotics. And especially the low MELD cirrhotics with the history of refractory ascites, variceal bleed, and hepatic encephalopathy, the MELD sarcopenia performs better to conventional MELD. Thank you.